Welcome back to Clinical Communication. Today, I'm speaking with Alan Taylor, who is a physiotherapist with a specialist interest in vascular flow limitations and cervical spine risk related to that, as well as being an associate professor at the University of Nottingham. In this episode, we'll be discussing around communication and things you should say before, during, and after doing cranial nerve tests with the patient in front of you. We'll go through each individual test and how we should communicate each one with the person in front of us. If you'd like more around the clinical reasoning with cranial nerve tests and how we should do them, then Alan has lots of papers and other resources which you'll find in the links for this. Thank you for watching or listening, as always. If you find it useful, please do go and share it with someone else, subscribe, and enjoy. Right, first of all, Alan, thank you very much for your time and speaking to me and everyone who's listening to this. What led you to being so interested in cranial nerve testing?
Yeah, thanks for having me on and giving me the opportunity to chat about all of this. What got me interested? Well, I guess to begin with, I was working in the sort of field of risk assessment related to the cervical spine and vascular conditions, so sort of arterial dissections and things like that. And as I started to read and understand more and more about those sorts of things, um, I began to realize that we got some limitations in our training, I think, is probably the way I would describe it. Because it became apparent to me that if we suspected a neurological issue in the upper limb or the lower limb, we would automatically go and do a neurological examination. But as therapists working with neck and head pain or complaints from patients, it became apparent to me that certainly my training, and it turns out the training of lots of physiotherapists, because there's been a couple of papers written on this now, didn't really equip, and that's not just in this country, it's in lots of countries. Didn't really equip us as therapists to be able to test the cranial nerves, which I thought was really weird. So, in other words, we were trained to do the lower limb, trained to do the upper limb, and then when we came to arguably the most dangerous or risky area of the body that we might attempt to do treatments to, we weren't doing a neurological screening. I thought that was absolutely fascinating, especially under the circumstances that physiotherapy finds itself in now, where we're sort of aspiring to be first contact practitioners and advanced clinical practitioners and consultant physiotherapists. It seemed that we just weren't equipped for that. And the other thing is, obviously, we see patients coming in with neck pain, head pain, they might have facial pain, they might have a range of symptoms, sort of numbness and other things that they might complain of, that made me realize that we were missing a whole raft of examination skills that we needed to be much better at. And then as I began to work as an expert witness, I think that became even more apparent to me, because when you work as an expert witness, you see cases where things haven't gone as smoothly as they might do in terms of the therapist's interaction. And maybe incidents have occurred because therapists have not acted in the right way. And I was kind of, I suppose, putting this all together and thinking, well, should we be much better at this? And that, I think that was the background to it.
I mean, I can vouch for that because just as you said it there, in my undergrad, and I realized this is over 10 years ago, but in my undergrad training, as you said, got taught the lower limb neurological examination, upper limb, no one touched on cranial at all. The first time I did it in clinical practice, and realizing when I needed to do it was having to learn it quickly off Google or Wikipedia about what the tests were and how to do them. Um, before we get into how accurate they are, why do you think that is, out of interest, that physio or
It's a
even
good
other professions
question.
as well?
It's a good question, and we're not entirely sure why. I've heard various. One of our undergrads did a survey, a study of qualified physiotherapists, and some of the reasons were it's not relevant. We don't have time. Um, we weren't trained. We haven't got the equipment to do it. There are a range of sort of reasons along those lines, really. And at the end of the day, I don't really believe many of those reasons held very much water because, you know, at
Mm,
the end of the day, if you can do a lower limb or upper limb assessment,
mm,
it's not that different to do a cranial nerve. There's a couple of little subtle differences, but really, you don't need specialized equipment. We've made that clear in that paper that we've written. And frankly, if you haven't got time, but you've got a patient who looks like they need to have a neurological assessment, you really ought to find time.
yeah. And it does take a bit from experience, maybe a little bit, but it's not drastically longer compared to an upper or lower limb neuro. Just,
No, and I think that's the other thing. I'm guessing that you'll probably use cranial nerve testing less often than you use upper limb and lower limb testing. So, in other words, you won't do it that often. But as you said, you know, we've got enough resources now to be able to use a crib sheet to do this if we can't remember it or have it, you know,
yeah,
you know, to be able to do it without. And I think there's nothing wrong with that. You know, you just have a sheet that reminds you, just the order or the order that you want to use, and run through the tests. I mean, I don't think that should be a barrier to be able to do these. And I think, you know, if we don't do certain tests or we default to the ones that we always do, then, you
mm,
know, when it comes to the time when you need to do a specific test, if because you can't remember it, you decide, oh, I won't do it, then that's not great decision making. It'd be
mm,
much better to just go to your computer, you know, find your crib sheet or your paper crib sheet, whatever it might be, or have it on the wall,
yeah,
and go ahead and do the test properly.
yeah,
I don't think we have many strong excuses for not doing them. It's obviously got to be appropriate, and I
mm,
don't believe that, you know, you have to do cranial nerves with every patient. It kind of fits with, you know, what the clinical picture is, and you know, so there's no sort of idea that this is something that everybody has to do every time. It's
yeah.
just when it is appropriate.
And this isn't just for physios either, but for any healthcare person who's almost acting, as you said, in that kind of the first assessment, first contact role, who may need to do it. Um, it's yeah, it would be to be appropriate. Um, but I agree with you. You know, we can't just make up excuses. You have to do it when you have to. How accurate are they? I realize there's various reasons why you would do it beyond just pain. But do we
Um,
know how accurate they are?
Yeah, it's a good question, and I think that will depend and vary widely according to the environment that these things are being used in. And I suppose a neurologist working in a specialist environment who does this multiple times daily will probably be a lot more accurate than a physiotherapist working in an outpatient clinic that does it every third month or something like
Yeah,
that.
yeah,
But overall, there's not brilliant data on this, but most of the papers I've looked at suggest that the accuracy and reliability of these tests is moderate across the board. So I think that would fit in with having somebody who's really accurate and then other people who are not so accurate and everybody else in between.
yeah,
But that said, these tests are used routinely by medics and emergency
yeah,
departments, you know, the
yeah,
world over,
yeah,
as a clinical assessment guide, prior to maybe asking for further investigation. So I think if we're aspiring as physiotherapists to be in this first contact practitioner role, we've got to be able to skill up to be able to, at the very least, talk to these doctors that we might be referring onwards about what we've done in terms of our physical examination.
yeah. So we're going to talk through what to say the bits before, during, and then after one's done a cranial nerve examination. Um, so the before part, and again, this is applicable for anyone who's going to do cranial nerve exams. How should we set it up to the person in front of them? What should we say in advance to help them prepare for what you're about to test?
Okay, I think this is a good question. It's very important that we're good at communication on this. And it's something we work with a lot with our undergraduate and postgraduate students at the University of Nottingham. Um, I guess first of all, what would be ideal is that we've already, in the subjective history taking part of this, um, asked a series of questions that relate specifically to the cranial nerve. So we might be asking if the patients have had any alteration in sensations around their face, you know, difficulties with swallowing, alterations in vision, alterations in hearing, etc. So we will have already gone through that with them. So they will have heard us talking about that at that point. Um, But in terms of setting up the cranial nerves, Ben, I don't think it's any different to setting up the lower limb or the upper limb. You explain to the patient there are certain elements of your presentation that make me think it would be wise for us to assess the function of your nerves. And because this is head and neck, we're going to be looking at how the nerves function in the head, neck, face, and that will include looking at things like how your eyes move, whether you can smell things, whether you can hear things, how your mouth and tongue and face works, whether you can taste things, etc., etc. And we'll be running through, and then we'll go to the head and neck and just do a series of simple tests around there. And a lot of this is around how the muscles and the sensation is working, and the function of the nerves. That would be my simple explanation to the patients before I went on to begin to do the testing, and then just ask if they were okay with that.
Mm.
The usual consent that you do always
Yeah.
whenever you do a physical examination.
Yeah. So we're going to go through the list of cranial nerve tests, and this is not in number 1 to 12 order. This is ordered as per Alan. One of your papers is cranial nerve testing for musculoskeletal conditions. And in that is a description of how to do them. And there's a recommended order by almost, is it more what's practical, more suitable rather than just in number order?
It's what's logical. It stops you darting around from place to place because it puts all the I ones together, and then it moves, logically through. Then
Yeah,
eventually finishes with the head and neck,
yeah,
which is 11, not 12.
yeah.
So, in our minds, when we wrote this paper, we were just going to, maybe a barrier to this is that it's so complex. You keep changing. You do something here, you do something there, then you go to somewhere else because you're following the order, that's been ascribed to the cranial nerves,
Yeah,
and that makes it quite difficult actually. And it's a bit odd for the patient because you do something with their eyes and then you move to somewhere else, and then you come back to the eyes later again. So
yeah,
it makes a lot more sense to do it in the order that, in our minds anyway, and I hope it is for other clinicians as well, to do it in this order that just is a bit more logical.
yeah. So, ironically, the order actually starts with number 1 anyway,
Yeah,
which is smell.
yeah,
Um,
yeah. That's a really easy one. We just explain to the patient we're just going to test their ability to be able to smell something every day like coffee or soap. And then it's very straightforward. We just ask them to close one nostril, and then we introduce whatever we're using, the soap or the coffee. And it's very straightforward. And just ask them whether they can smell it equally in each nostril with one nostril covered. And that's very, very easy. So that's one of the easiest ones to do. Um, when it gets we go straight to, so we go from smell to hearing.
yes.
So that's vestibulocochlear. So that's number 8, isn't it? Yeah.
Yeah.
And really, again, explain to the patient we're just going to now test another sense, and that is your ability to hear. And there's many ways to do this. I've seen lots of different ways to do this. All I do is just rub the fingers and ask the patient whether they can, from behind. You stand behind them and then just ask whether they can hear that clearly in each ear. There is an option to use tuning forks with this, but you'll probably find when you do hearing tests that most patients can hear the rubbing of the fingers on either side. Some people whisper a number, whatever it might be, it doesn't matter. It's
No.
just something that you would do on either side. And in all the time I've been doing this, I've never actually had to resort to using tuning forks for that. So I'm not saying don't use tuning forks, but you'll find that most people will hear that little rub of the fingers on either side.
Is that
Uh,
also something you could crop up in the subjective as well if there's hearing
Yeah,
issues?
yeah, yeah. That's the other thing. But the other thing is getting the baseline though before you start. So if you've done that in the subjective, have you had any difficulties with your hearing previously where you've had to go for hearing tests or anything like that? Because they might have had, in which case their hearing will be impaired and it might not be anything to do with the cranial nerves. Same thing with vision. Have you got any, have you been to the optician? So we need a baseline before we start. And I guess that comes out in that early subjective history.
Yeah. So we've got smell, out of interest with the smell, if they have a cold at the time or something's blocking their nose.
Again, this is about reliability of testing, isn't it? So if before you start, you would ask that sort of thing. And if they're saying yes, then, when we test it, we're not going to be too sure, are we? So I think we
Yeah,
have to be cautious with our interpretation of
yeah.
tests.
Yeah.
get those baselines.
Yeah.
Really important.
And so then after smell and hearing, we then get to the battery of vision tests.
Yeah, so you basically go in, do all of the ones that involve the eyes. So you go to two and do visual acuity and field of vision. So again, people say, "Oh, well, I don't have a Snellen chart," but you don't need a Snellen chart. You can just use the newspaper or anything with some print on and just get them to cover each eye and check whether they can see clearly. We're not opticians. We're not trying to do anything complex. It's just really whether the vision appears to be the same on either side. And then the field of vision, you go around the field of vision using, there's various techniques for that again. But explain to the patient, we're just looking to see whether the eyes are functioning normally. That's all we need to explain to them. We don't need to talk about, use words like acuity or anything, complex.
No.
Then we look at ocular motor, number three, look at the eye movements. Look at the eyelids. Observation of the face is really important. So you're looking for any drooping of eyelids, uh, alteration in size of pupils. This is really important. And then the only tool I think you will need is probably the pen torch, where you might want to look at the pupil size and the reactivity to light. So this one is important that you communicate this one to the patient, where you say, what's going to happen now is I'm just going to look at the pupils and I will be shining a torch into your, it's not too bright, but a torch into your eye. Are you okay with that? So once again, it's getting consent through and explaining each little bit that you're doing. And you can do it on your own eyes first, so the patient knows what that looks like if they're a bit anxious, and some people are. So, just sort of assess the situation, and then you can shine the torch into their eye, and you will sort of put the cover between the two and look for the reaction in the other eye as well. And again, you just do the test, you don't pass comment, you carry on like you would in a normal neurological situation and just keep moving through. Then we look at trochlear eye movements, side to side, adduction, and then we get to abduction with the abducens nerve. And then you've done all of the eye stuff together. So you've done a block, um, 2, 3, 4, and 6. So that's the numbering of that, and that means that you stay with the patient doing the eyes for that whole block,
Yeah.
and it sort of makes sense. Then after that, what we went to is trigeminal, which is 5. That was the one that was missing. You will have already asked in the subjective whether they've been having any difficulty with chewing or any sensation issues around the face or mouth. Personally, I don't do the corneal reflex. Some people insist that that should be done, but lots of people do miss that out of this. And because it's absent in lots of patients anyway, so that isn't a particularly reliable part of this test. Facial, number 7, which is a mixed nerve. This is where we look at the facial expression. We explain to the patient, we're just going to look at you pulling some faces now, and the best thing to do is probably just mimic those faces for them, so you can puff out the cheeks. Do all the other things that you do. The sort of furrowing of the eyebrows and et cetera, and let them see what it looks like, and just get them to mirror it. And just explain that you're just testing for muscle function. That's all you need to test for. You can look at eyelid closure there. You can try to then explain to the patient there, I'm going to ask you to close your eyes and we're going to try and check whether they'll open or not, but don't let me open them, would be the command to the patient. And again, there's another corneal reflex, which personally I just don't do there. Glossopharyngeal comes next. That's number 9. And you will have asked already if they've had any difficulty with gagging or swallowing. You can get them to just swallow some saliva or a drink of water or whatever with that. And then also ask them whether they've noticed any alteration of taste. But you probably did that in subjective anyway, but you can ask again just to be sure. Vagus, number 10, again asking about gagging, swallowing, and this is the one which you would have asked in subjective again, but we'll ask again. Is there any alteration in your speech? Have you noticed any alteration in your speech? And again, obviously, if they've had a cold or a flu recently, that might be a normal thing. So we've got to take that into account again. Then we get into, actually 12 comes before 11 in this order. So we're using hypoglossal, number 12, and this is where we get them, explain to the patient, we're just going to look at the tongue function, ask them to put their tongue out, look inside their mouth, look at the uvula with the pen torch. That's the one tool I think you probably do need. You will have heard them speaking already because you've been talking to them throughout the whole session. And then you will just test the strength of the tongue as well. You explain that you're just going to ask them to push their tongue out into the mouth, and you push against the tongue and just check that they're okay with that. And then we come to accessory, and we just do those basic sort of rotation and shoulder shrug tests to finish. And it's done in that order. I hope you agree. It's actually very logical and not a difficult thing to do, I don't think. And once you've done it a few times
Yeah.
and you've got your crib sheet, you'll be able to whiz through that as quickly as you whiz through a lower limb or a upper limb, I think.
Yeah. I have interest with the pen torch.
Mm.
As you say, many people won't have one. Does the light on a phone, will that do the same job?
I'd be a bit cautious. You'd have to be quite a long way away. They're very bright. So
Okay.
we've discouraged our students from using them
Okay.
because they're a bit too bright for lots of people. So the pen torches are just a bit dimmer, but bright enough to have the response on the pupils and that sort of thing. So yeah, I'm not a big fan of using the phone for that.
Fine. Fine. And as you said, you go through the tests and just nodding or acknowledging the response. At this point, we're not making comment yet or judgment about it. You get through the list, and I presume, especially if more MSK environments, a lot of the tests predominantly can be okay. We're not going to see anything.
Predominantly, I think they really are. I think and I suppose this is the bit that's kind of important though. It's kind of good that you've done that because that then goes in the notes.
Yeah.
And that's where I'd be looking if I was an expert witness looking at a case where something had not gone perfectly. That's where
Mm.
we go to the notes and the testimony of the therapist if there has been an adverse event. So it's kind of, we're not saying just do it for that as a protective medicine sort of thing, or a protective actions, to prevent, sort of a legal case. But I think with all tests that we do, we put them in the notes and just say, actually, we did it, but it was negative.
Mm.
I think that is helpful, and it shows that you've been logical, and you will have also detailed in your clinical reasoning that you did the cranial nerves because there was some particular headache, particular type of headache, or the patient had complained of something in particular that made you think maybe I'll do the cranial nerves, or you observed something such as facial asymmetry or an eyelid issue or a pupil issue that you thought, well, maybe we'll do the cranial nerves.
Can we say if that all comes back okay at that point, can we say to that person that we're happy that the nerves coming from your, in this case, I guess, brain or brainstem are okay?
Yeah, so yeah, we've done all the tests, and as far as I can see today, that all seems to be working perfectly normally.
Fine. Now, what if
Yeah,
there's going to be the occasional person where something doesn't um, fit?
yeah.
There is some things that aren't normal. Previously, when people talk about lower limb or upper limb, they'll say maybe the nerve is irritated. They can make judgments off that. But what should we say to the person at the point where there may be things that aren't normal on cranial nerve exams?
It's a great question, and one we often get asked. And I think the main thing is that this all depends entirely on the big clinical picture. You've got to remember that cranial nerves are not the be all and end all of your testing. You've
Yeah.
got lots of other things that you will have done already. You've got your subjective history, which perhaps some people will suggest is 80% of your information that you'll use for your clinical reasoning. And the cranial nerve tests are just one very small part of that. So for me, I think we have to first of all accept the tests are only moderately reliable,
Mhm.
and that you, as a therapist, probably only perform them once in a blue moon. So you're probably not as proficient as you might be at doing them. All I would do if this was a case that didn't, what shall we say, all I found was, maybe a single cranial nerve or maybe even two were mildly or moderately affected in some way. all I would do is say, well, what we found today is a couple of minor things. What I think I'm going to do is, and providing the overall condition allowed me to do this. In other words, it didn't look like an urgent case. I'm just going to write a letter to your GP and ask them to just recheck these things and then refer you if they think there's anything similar to what we found today. So nothing to worry about. It's just a double check. But I think, as with all cases, if you've got lower limb and you think there might be from your neurological testing a sense that there could be a cauda equina or something more serious happening in the spine, a tumor or whatever it may be, I think we've got to consider the urgency. So I think there will be. I've only ever seen one, but there will be occasional cases where we might think this has got to be a lot more urgent than a letter to the GP. It could require even a visit to accident and emergency, because some of these things we're looking at the precursor to stroke, or something much more serious, or aneurysm, or something like that, or some kind of vascular event. So there's a range. It's not always vascular either, so there's a range of things that we might consider much more urgent, in which case we would be on the phone to, wherever you would have to contact in your trust, and we'd be using a situation background assessment recommendation, SBAR type referral, for those sorts of patients. So that would be an immediate sort of response, even in the knowledge that, our testing might not be 100%. I think if you think you found enough things and the big picture, in other words, maybe the patient is getting worse, or maybe they've got something else like a really high blood pressure or something else that you've taken, or maybe there's something that is making you suspect that this just needs to be a lot more urgent. Then I think we have to make those sorts of referrals then, regardless of the fact that we know the tests are only moderately reliable.
I presume, someone who's presenting with symptoms at that level that you're concerned then may need to go to A&E or get really urgent care. There's a highly likelihood that they've clocked it themselves, probably before they come to see you, and they
Uh,
may feel that you may need to go this way anyway.
Yes, no is the answer.
Oh, okay.
Maybe not. I can tell you a simple case right now,
Cool.
where you would have thought they would have clocked it, but they hadn't. So it was a neurological physiotherapist that came into my musculoskeletal clinic following a road traffic accident, I think 2 or 3 weeks post road traffic accident. And I went out to collect this lady who I'd spoken to on the phone but never met. And I went out to the waiting area, and I leant forward to sort of shake her hand and say, come on through to the clinic, Mrs. X, or whatever she was called. And as I looked at her, starting your physical examination almost straight away, I did the observation bit, and I saw that her face was asymmetrical. And anyway, cut to long story short, we found some cranial nerve issues. But this patient, she was a neurological physiotherapist. She was in the best place
Yeah.
to be able to recognize this, and she'd not recognized any of these
Mhm.
symptoms.
Wow.
So that's just one case, but maybe they would. Maybe somebody would look in the mirror and see that. I don't know. Maybe they'd notice that their taste had altered. I mean, they might put it down to the cold that they had last week.
Yeah.
Maybe they noticed that the hearing was being affected. They might put that down to going to the gig that they went to last week. People always find a reason for one thing or another. So the answer is I don't know, and it will depend on the individual, I think.
Yeah. Yeah. Um, before we go on to the next part, is there other things about communicating or speaking with patients around cranial nerve tests, whether it's before, during, or after, that you want to raise that we've missed? What you want to say?
I don't think so. I think my main thing would be to just say that this is perfectly routine. It's
Yeah.
normal.
Yeah.
We should think of it as just the same as doing a lower limb or upper limb neurological test. It is. It involves some extra bits and pieces, but it's nothing out of the ordinary.
Mm.
And if we find things, we don't need to fly into a panic. We need to realize the limitations of these tests anyway, make appropriate referrals. Um, and above all, don't alarm the patient, as best as you're able. But obviously, if there is an urgency, you will have to find a way to explain to the patient that this should be seen sooner
Yeah.
rather than later.
Yeah. Now, before we get into your hardest question, I was listening to something you did before, and I knew that you were had a kind of expert witness role in medical legal work. And I was very curious to ask, and knew I was going to ask this. So, as a as a physio and assistant professor as well, um, what is it like doing medical legal work, and who should consider doing it?
Right. Great question. Yeah. Well, what is it like? It's challenging, but it's interesting. So, these cases come along every now and then. It doesn't, I don't seek them out. They sort of come in my direction. Um, and you've got to be prepared to do some hard work. And you get to, it's interesting because you get to see lots of system failures.
Mhm.
You get to, often it's not down to the individual therapist. You have to look at the big picture again. It's all about sort of looking at everything that happens. And it can be down to system failures within the hospital around training. It can be a range of different things. It can be failures around the sort of tests that get done, etc., etc. There's so many sort of points of failure in these sort of episodes of care of patients. It's really quite fascinating work, and you have to, often, use perhaps root cause analysis to look at the big overview of these sorts of failures. So it's really, really interesting from that point of view. But you have to be prepared to do, I suppose, the donkey work, where you have to look through all of this information and be able to make sense of what's happening with these cases. So, who might be suited to doing now? That's the most interesting part of it. First of all, those who enjoy trawling through literature and have a sort of detective-like mind, but above all, you probably need quite a robust personality, and by that I mean, if you go, and I'm not sure they still do it at the CSP, but I did my training at the CSP, and it was probably the training session that I recall most of all, from everything I've done through all the years of physiotherapy. And that's where you go and work with the lawyers, and they put you into the witness box. And that's quite a harrowing thing, because basically what happens is the lawyers try to belittle or destroy your persona whilst you
Okay.
stood in the witness box. So if you feel able to deal with that, maybe you might be suited to it, and be able to respond to the way they pose their questions, then you may be suited to it. But believe me, a lot of people went on that training and decided it wasn't for them.
Okay. Mm. So if one is interested, is it just a case of contact the CSP, and is there just a training and you go on a list?
Yeah, I'm not sure the CSB still do it. I think they may, but certainly there'll be lots of firms that do, and I'm pretty sure they'll use that same technique, because basically it puts you into that place, and I guess it's almost a test of whether you really want to carry on with this, really.
Yeah.
And I thought twice about it, because it's not a pleasant experience. It's their job basically to make you look foolish, and they
Yeah.
try their best to do that,
Yeah. Fine.
which is tough.
Um, and for the right person can be enjoyable and
Oh
rewarding.
yeah, no, sure. But bear in mind, you can be an expert witness and never go to court. So even
Mm.
if it prepares you for the worst case scenario, you may never actually end up in court. You may never have to suffer that, sort of difficult situation that I've just described. But in which case, you'll spend most of your time looking through stuff, interviewing people, chatting to people, then looking at the evidence and looking at the body of evidence that, other physiotherapists may have applied to a similar case. And then you have to balance this all up and then do a really nice balanced report that uses the evidence, and puts it all together. And that's the report for the court. And then obviously, then questions get asked.
Yeah.
And if it does go, most of these get settled out of court, is the bottom line. So
Okay.
you,
Oh,
you could be fearful of having to go to court, but maybe you won't ever go.
no.
So it's a bit of a lottery, but I think you've got to be prepared to go if that happens.
Okay. Fine. So Alan, ask everyone this, and maybe it's the person you mentioned earlier, but ask everyone, whether it's one example or many, what is the hardest clinical conversation you've had?
Yeah, I can recall this very well, actually. In the earlier days of looking at vascular flow limitations, when I was looking at the lower limb, which I still do, but I remember this particular case. I'd seen a few, not many, but because they're rare anyway, but I'd seen a few. cases of flow limitations to the lower limb in elite athletes. And a young guy came to see me, 18-year-old student who was already an elite cyclist, but he was aspiring to get to professional level.
Mm.
And he came into the clinic and we did the usual, we did the subjective, and then we went through the normal sort of clinical objective, and then we put him through the exercise tests, ankle breaker pressure index after exercise that we do with these particular athletes. And again, this is a case of ensuring that, when you're doing your clinical tests, you've set them up in a way that isn't too alarming for patients. So when we do these tests, we get the individuals to exercise to the point of their reproduction of their pain. Then we have to put them back on a couch, and then we take the blood pressures at the arm and the two lower limbs. But the two lower limb blood pressure monitors, we have to make sure we've turned away from the vision of the patient, because if these tests are positive, you see that one leg is a particular number, let's say it's 180, and then the affected leg can be as low as 50 or 60, and it's really obvious to the patient that there's something quite serious going on. But anyway, that was more or less what happened with this particular individual, 18-year-old. We did his tests, and there was a vast difference between the non-affected leg and the affected leg, which I see very, very clearly. We did the calculations, sort of got him to, go and get changed and then come back into the office. And I had to talk him through the fact that essentially what he got was from the testing that we'd done, and it will need repeating, but that he got what looked like a significant flow limitation to the lower limb, and that he was probably going to have to go on to have a major surgery if he wanted to carry on down the route that he was going, which was competing at elite cycling, and aspiring to professional level, because the significance of the test that we did that day was over and above some of the ones we'd seen previously. So I had to talk him
Mm.
through that, and then send him as a referral then to the vascular team in the area where he lived, and they repeated the tests and found the same things. And he did go through eventually and have a successful surgery, but he didn't make it on to professional level in the end. But it was that was probably one of the most difficult conversations, just because he was asking lots of questions about, oh, how will it affect me? Will I be able to do this? Will I be able to? Do you think I'll still be able to be professional and all those things? I just had to say, well, it will all depend on how this goes from here on, really. So it was a bit of a tough one.
Yeah, there's lots of, it sounds like lots of having to say, I don't know,
You
essentially.
have to, and we don't know. So
Yeah.
first of all, I'm saying we've done the tests here today, and with the equipment that we've got and the skill level we've got, this is what we found. They might do them in another 3 weeks' time and find something slightly different, but prepare yourself that there is something not
Mm.
quite right here. We have to be very honest with the patients under those circumstances. Yeah.
Out of interest, if he wasn't trying to become a pro cyclist and was just living a, well, non-pro cyclist life, would he have ever have known?
It's a great question. He's got quite significant flow limitations, so maybe not. It was only his symptoms were only occurring when he got his pulse rate maybe above, 140.
Yeah.
So that requires a significant effort. So if all he ever did was go down to the local shop or the pub, you probably wouldn't get his heart rate that high. So maybe he wouldn't have known is the answer. Yeah.
Mm.
But they think these things actually, this endofibrosis condition seems to occur in high level athletes anyway. So
Mhm.
in a way, the two things go hand in hand. But certainly you can have flow limitations that you wouldn't know about because they're not so significant.
And thank you for sharing that. It's important that, people hear that, yes, we have nice conversations, but obviously conversations can be difficult as well. And they're often the ones, as you said, that you remember, rather than the many people we see who thankfully get better. I like to end these on a positive note or a more uplifting note. You and Roger Kerry have a country music band. Uh, how did that get formed? And what led to that?
Right. Okay. So this is quite a long story, but I'll cut it short. First of all, what you mustn't do, Ben, is mention country music.
Okay, sorry.
It's all right. I know it's very sort of popular all of a sudden now, country music, but no, we're only kind of joking up to a point. But we've always set ourselves up as an Americana band and an
Yeah.
alt country band, right?
Ah,
A little bit of folk as well, and and to sort of prove that point, we have got one song. We've only actually got one country song, and it's called "I Don't Sing Country Anymore."
okay.
But I've got a confession. I just wrote another country song. But anyway, let's leave country music for a minute. We've just released an album of reworked traditional folk songs, which is about as far away from country music as you can get. But how did it all happen? There is a physio link here. Back in the day, way back, we used to do some courses. Roger and I used to travel around the country doing these altered hemodynamic courses. And whenever we used to take our guitars, and so whenever we were in the hotel, we'd either be down in the hotel lobby or up in one of the rooms upstairs, just playing songs that we'd just been tinkering around with, until the concierge would phone and say, "Gentlemen, it's time to stop singing because everyone's trying to get to sleep," sort of thing. And it developed from there really, and we just then just wrote a few songs, not together, but we worked on each other's songs. And then almost by just over time, we gradually worked with a few other musicians in the local village here where we are. And there's a particular pub where lots of musicians go to. And then we ended up forming a band, really. That was it. And then on it went. And we've just recently, we've got to the point now where we have an annual sort of winter party for the students at the university. And we just had that in earlier in November. So we're on our fourth album now.
Fourth.
So we're just about to go back into the studio to start the fifth.
Oh.
I've not told the rest of the band that yet. Don't mention it. Yeah, but yeah, it's pretty much Americana. And as we say, old country with a little bit of folk. So, but this new country song that I've written, I don't know whether that's going to go anywhere or not. We might just save that another time.
Is there a large in the UK at least a large Americana following?
It's not massive. No, Americana is quite a small genre. There are a number of folks. I'm going to in January. I'm coming down to London. There's an a small Americana festival on there. There are a few festivals that do focus in on that. Yeah, but it's relatively small compared to some of the other sort of genres that you might be in.
Mm.
So we're a small fish in a small sea.
And
But
you sing?
yeah, yeah. Roger and I, we share vocals,
Okay.
so we probably more or less maybe sing our own songs that we write, maybe co sing on the other ones, and then because we've done some traditional songs, it's probably the ones that we reworked individually that we sing on. We did a version of Poor Wayfaring Stranger, and we shared the verses on that one. So yeah, that's how it works. Very much a team effort.
Mhm. And the students like it as well at the winter.
Well, you'd have to look at one of the videos, Ben. It looked like they were enjoying it to me on the last video that we did on Instagram from that party. Yeah, yeah. If you look at the Lawrence County Instagram and scroll back into November, you can see for yourself. I couldn't judge on that one.
The band is called Lawrence Country. You just said it. Uh,
County, county,
County.
Lawrence
Sorry, not
County.
country. County.
You said we're not going to talk about country. No, it's Lawrence County because this is where D.H. Lawrence was from.
Okay.
Kinghamshire. Yeah, it's where D.H. Lawrence used to hang out.
Yeah.
That's where the band name came from.
And people can find that on any social media or YouTube.
Pretty much, yeah. We try to direct people to Bandcamp because that's where we actually properly get paid. But you'll find it on everything else. So you find it on Instagram, you'll find it on Facebook, you'll find it on even Twitter or X, whatever it calls itself now.
Yeah. And you are on Twitter or X,
Yeah,
LinkedIn and Instagram?
yeah, I don't use Instagram as much as I should, but yes, yeah. I mean, we've almost reached the point now with Twitter where we're going to all have to stop using it. I think it's just got too much of a cesspit, hasn't it, out there,
Yeah.
really? But yeah, I don't use Facebook at all, not for work. But my main presence has probably been on X or Twitter as it was. previously. I need to perhaps work a little bit more on the Instagram element. Yeah. And there are the YouTube videos as well. Oh, and what is interesting, I suppose, if you're interested in this cranial nerve stuff, is that I did a video where it was like a telehealth version of a cranial nerve test where I,
Ah.
patient as a telehealth consultation. Yeah, those things can be done, perhaps not as effectively as face to face, but I think we can get a sense, even from a telehealth consultation, as to whether the cranial nerves are functioning or not.
And we can put all the links in description for the social media and the YouTube channel. Obviously, you've done various papers, which I'll put a few in the description as well. Um, Anything else to plug or to
Uh,
share?
Not for now, no. I mean, I've just recently just put up a little thread relating to the external iliac artery thing
Mm.
on X, and quite a few people have hooked into that. It's been nice to collaborate with some other researchers. So occasionally, it does good things do come out of X.
Mm.
So that's been useful. So if anybody wants to look at some of the vascular flow limitation stuff, there's a I don't know, 5 or 6 piece thread there, which just gives a little bit of background detail.
I've learned for X or Twitter that if you keep your followers to a small amount, then that often helps it become less messy or cesspit, as you say. And you can mute people as well without offending
Yeah,
them
no,
by unfollowing
yeah, I've got a few people muted. I'll be muting a few more soon as well.
them. Alan, thank you for your time
No,
and
it's
speaking
been
to
a
me
joy, man. Thank
and,
you.
and talking about this niche topic because I agree with you. It's something, as you heard me say earlier, I was never covered when I was trained. And oftentimes people may come across it the first time they actually have to do it. And there's lots of resources now about what to do, from yourself and others. But just going about how and the words to say is important as well. Thank you very much.
Final thing, and you just reminded me of that when you said lots of resources. I think I've been lying to you the whole way through this because, in actual fact, we did write a thing called the Cranial Nerves Country Song.
Did you?
Forgotten all about that. That's somewhere on YouTube when the band had
Right.
got a different name.
Yeah.
But yeah, we won't put that one in there. If somebody wants to search it, they can find it.
Fine. Fine.
Yeah. But thanks very much for that. It's been good talking to you.
Thank you, Alan.